Welcome to today's webinar, Resources for Reducing Readmissions in Inpatient Psychiatric Facilities. I'm Candy Hansen, a program manager from Stratus Health in Minnesota. With me today, I have John Glover, project specialist with Metastar in Wisconsin, and Barbara Link, senior quality specialist with MPRO in Michigan. We're so happy you joined with us today. Whoops. All right, just a second here. There we go. So our objectives for today's webinar are to learn the basic skills or to learn about the basic skills to prevent and de-escalate mental health crises, understand how the Readmit Tool can help determine the risk for readmission following an inpatient psychiatric stay, and we're going to explore some strategies on how to improve the discharge process to reduce readmissions. You probably already know this, but our 3 states currently make up the Lake Superior Quality Innovation Network. We will soon be known as the Superior Health Quality Alliance in the near future, and we'll be adding hospital partners and other stakeholders to our team. I'm going to start by sharing with you a mental health video training series that Stratus Health did in collaboration with one of its coordination of care communities in late 2018. It was originally designed for working with mental health clients in nursing homes, but has much broader relevance to a wider audience and has some really great information in it. It's for those care providers and caregivers, especially those without formal clinical training programs. Although I'm a nurse by background and having viewed it several times, I think it's a great refresher on just some basics about working with people with mental illness, especially older adults, as well as some techniques that might seem kind of obvious to us, but I think it's always good to have a place for reminders. I also see relevance for family caregivers, especially in the first video, which I'll talk about in just a minute, because it does a really nice overview of the categories of mental illness. It also has relevance for direct care staff. I can see it being used for annual training or orientation for people working with behavioral health, clients with behavioral health needs. I just see a whole variety of uses for this video series. Each of the videos is less than 30 minutes in length, and as we go through them, I'll remind you how long each one is. And as I said before, even as a nurse who's been in practice for over 30 years, I just thought these were really good refreshers. And you know, I think that we can never assume, as I mentioned, some of the de-escalation techniques, when I'm smiling as I say this, because when I was watching it, it was like, are you kidding me? You'd never talk to someone like that. But I don't think we can ever make that assumption that people just don't, not even out of, you know, malice, but just get really frustrated sometimes. And so it's just really some good reminders in there. So the training goals of the video service were to boost understanding of older adult mental health, to equip providers and caregivers with techniques to prevent and de-escalate behavioral crises that may lead to unnecessarily hospitalization, as well as could be potential safety issues for both clients and caregivers, which ultimately will improve behavioral and mental health outcomes for older adults. And again, I think anything we can do to address the stigma around mental health and encourage more education and training is always a helpful thing. The first video is called Older Adult Mental Health Basics, and it's 23 minutes long. As I said, it explains common mental illness disorder categories. It shares some compelling statistics, addresses the fear and inadequacy many providers and caregivers feel. It confronts stigma and derogatory labels, and I think it expresses hope and talks about treatment and how it can be effective. It conveys how you, as a care provider or family caregiver, can support, and it provides resources for more help. I think this first video would be helpful for an older adult who has been diagnosed with a mental illness for the first time, or for someone who has been struggling with one for some time. I think it does a very nice job of normalizing mental illness as a chronic condition. It talks through issues such as depression, anxiety, substance use disorder, bipolar, personality disorders, and schizophrenia, and post-traumatic stress disorder. The second video, Preventing and De-escalating Mental Health Crises, is 27 minutes long. It describes common behaviors and triggers likely to cause behavioral events. It suggests prevention tips to reduce behaviors, and it describes the cycle of crisis escalation. It also has a couple of vignettes where it does role-playing and demonstrates the right way and the wrong way for de-escalation scenarios, and how to apply new learning after an event. And in addition to that, it offers some additional resources. In a couple of minutes, I'm going to play a short excerpt from this video to give you an example. The third video, Person-Centered Care and Collaboration, is 17 minutes long, and it describes the importance of individual behavioral care plans and creative solutions to diminish or redirect behaviors, when to consult with outside, as well as when to consult with outside professionals. It also describes for you the steps for actually implementing a person-centered care plan for someone with behavioral health issues. Each of the videos has a 10-question quiz that is available. And it also then has so you could do this in two methods. You could either fill in the quiz answers, sort of as an open book test as you're going through the video, or you could just provide a quiz after viewing. And then after checking, for answer checking, there's another resource then that gives you the answers for each of the questions. For each of the videos, there's a fact sheet on the 3 topic areas. You could use the fact sheet as a separate handout, or it's something that I think would go well to post in a break room for staff as well. And then third, there are some pocket-sized action checklists. So if someone could carry these and apply them during their work, or they could be posted on a med cart or something, just reminding you about some things about dealing with people with behavioral health issues. And then there are sample plans and templates for each video. The Geriatric Depression Screening Tool is available after the first video. There's also a sample crisis plan for the second video that I really love, because it's an interactive plan that can be done with the patient or client, and it's really an opportunity for them to think about and to talk over with you. A prevention plan where there are things like, what are their triggers that they can think about? What might be some of the physical symptoms we could expect to see if they were feeling that their illness was triggered by something when they're going into crisis? And also things that make them feel good, and things or ways that have been used in the past to help calm them down. It helps you do this in a proactive manner so that the caregiving staff is aware of these things and can use them to build upon the client's strengths, as well as to use what the client has identified that already works. And so I really like that particular tool. And then what's shown here is a person-centered care plan template. It's got things that are very person-centered about things that that are important to the client. And again, I think the combination of all of these tools really helps you to know your behavioral health clients at a different level, and be able to interact them in a way that that some staff might not have thought of doing in the past. So I'm going to take a couple of minutes in just a second here to play just a 2-minute excerpt from the second video, and I hope it will work on the browser that you are signed in on. But if not, you should still be able to hear it on your phone. And as I said, it's only like 2 minutes long. So if you can't, I ask you to stay with us even if you have some technical issues seeing it. All right, here we go.
Here's another common situation. You come upon a person who is physically agitated and verbally abusive. You need to de-escalate behavior that might lead a person to hurting himself or others. In this clip, the caregiver sees John physically agitated. He's pushing his food away and yelling at everyone to leave him alone. The caregiver is worried John might hurt himself or others.
John, stop it right now.
I can't stand this place.
Calm down.
You calm down.
Listen, I'm in charge here, not you.
Get your damn hands off me. You're the meanest person I ever met. I get a headache just looking at you.
You are the stubbornest person I ever met.
Hit me. Go ahead. Hit me. I dare you.
How did things spiral out of control so fast? What actions did the caregiver do that you should never do?
Someone were to do a clothing grab and grab my shirt, I'm going to do a windmill and spin my arm away and use leverage and momentum to get away from something like that. If someone's going to try to take a swing at me, I'm going to try and block it and use leverage and momentum, and I'm going to go away.
Let's take another look at the same situation again.
Hey, buddy, what's wrong?
Sick and tired of this place. Leave me alone.
It sounds like you would like to be by yourself for a little while.
It's so noisy. I have a headache.
I'm hearing that your head hurts. How long has this been going on?
Since last night. I hate this food, and I hate you too.
I think we should go to see Tommy. You know Tommy. She's our head nurse, the one who helped you when you had pneumonia.
My head really hurts.
That's why we should see Tommy. She might be able to give you some medicine for your pain.
That would be great. I can't concentrate.
I understand. It must be very tough for you right now.
I'm really glad you're here tonight. Thanks for listening.
Okay. Back to our screen here. All right. So I hope that was just helpful for you to see. As I said, you know, when I look at the first scenario, I'm like, oh, I don't think anybody should ever be talking to anyone like that. And hopefully that's not the case. But as we know, sometimes people just get really frustrated and don't act in the way that they've been trained. So all of the resources I've described today can be found at the link in the slide, in this slide, and the slides were sent out to you on Monday. And so if you click on that link, it'll take you to the Lake Superior Quality Innovation Network website, and all of the resources that I mentioned earlier are all on that one page. So you'll have the first video, and then the accompanying resources, the second video, and so on. So I hope you find value in this free video series in your ongoing work. I didn't mention it when we got started, but we're going to just ask you to hold questions until the end so that we can make sure that we all get through all of the topic areas. So now I'm going to turn the presentation over to John Glover from Metastar in Wisconsin. John, and you just tell me next slide, John.
Great. Can you hear me okay, Candy?
Yep, I can hear you just fine, John.
All right. Thanks a lot. That was really great. Those are great videos. I hope people are able to access them and make use of them with their employees. I'm here today just to talk to you briefly about the Readmit risk stratification tool. You can go to next slide, Candy. The Readmit risk stratification tool comes from the model developed by clinical researchers at the University of Toronto in 2014. It's the only tool we're aware of that was specifically developed for the behavioral health population. And we know that there are other tools that general hospitals use, like the LACE, but these often don't have a behavioral health component to them. And this particular tool used a really large population of data that included about 32,000 records, and they did a retrospective use of this data to create the various categories that are used. Next slide. Next slide, please.
Hang on, John. Just having a little bit of trouble here.
Yep.
Go up to the top. 1 second.
So what we're going to do is we're going to talk just a little bit
There
about
we
what
go.
risk stratification is. There we go. Risk stratification is a process of assigning risk status to a patient in order to better direct their care, apply appropriate interventions for them, and improve their overall health outcomes. So this is the goal, and now we're going to take a look at the Readmit model itself so you can get an idea of how it works. Next slide. There it is. So here's the basic categories of the Readmit model. The first one is repeat admissions, and this has to do with how many admissions has the patient had in their lifetime. Next is emergent admissions, and this is when the person is a threat to themselves, a threat to others, or they're unable to care for themselves. Then we have age, and this category is broken down into about 9 different groups. The lowest score for age is in the 94 and up category, and that's a 0. The highest score you get for age is in the lowest or the youngest population, which is the 18 to 24-year-old. Then next you have diagnosis and discharge status. Here you'll get particular points for the diagnosis that the patient has when they're coming into the hospital. This can include personality disorders and also any unplanned discharges that the patient may have had in the past. So that will give the patient, I think it's 5 points for an unplanned discharge. The next area is the M, and that has to do with medical morbidity. This particular section uses the Charleston comorbidity score over the past 2 years, and we're going to talk a little bit more about that for those of you who may not be familiar with it, just to give you a sense of what that looks like. We've been able to develop a pretty quick way of getting that score. And then the I stands for intensity, and this is the amount of outpatient and emergency room contact the patient has had in the last year. And then finally, the T stands for the time in the hospital. And since we're doing this on admission, we're looking at the amount of inpatient days we're expecting to have. The first category really goes up to 14 days. So I'm assuming that most people are going to be hoping to get a patient in and out within that time period. Next slide, please. Yeah. So our team created a tool in Excel to automate this process using the data from their original study that the clinicians in Toronto did. What we did was use their distribution of scores to create a low, medium, and high categories of risk. The scores can range from 0 to 14, and you can see here on this slide that the highest category of risk indicates 26 and above, and these people showed a risk of 30-day readmission that was 20% or greater. And when we look at readmission rates, people in that particular category are definitely the ones more in the high risk category. So one of the things that I thought was really interesting that a colleague of mine pointed out was that even though people in the high risk category very clearly would benefit from additional attention and support while they're in the hospital, actually even people in the medium category would still benefit or warrant some increased attention to make sure that they were not readmitted within 30 days. So the nice thing about the form is that once you've completed it, you can record the results and then clear the form to allow for the next patient to be scored. So let's take a look at it. Next slide. So here's a screenshot of what the form looks like. you can see that each risk factor has a description of the variable that's being evaluated, along with a value that is associated with that variable so that points can be attributed to it. And we'll see what that looks like here in a minute. But I'll walk you through this particular slide. Repeat admissions, if there's 1 to 2, you get 2 points. If there's 3 to 5, you get 5 points there. Emergent admissions, you get a point for any one of the categories of either threat to others or threat to self. You do get 2 points, though, if the patient is unable to care for themselves. And then the age category, like I said, is divided into 0 to 8 scale based on how old the person is. The older the patient is, the lower that point value is. The younger the patient is, the higher the point value is. And then the D for diagnosis, you're looking at their primary diagnosis. Give you a quick rundown there. Depression, you'll get 2 points. Psychosis or bipolar disorder will give the patient 4 points. Other psychiatric diagnoses give the patient 3 points. Then under personality disorder, that's 2 points if they have a diagnosis there. And as I said, any unplanned discharges that may have occurred in the past, that's 5 points. So next is medical morbidity, and this is where the Charleston comorbidity score comes in. And like I said, we're going to look at that in just a second, but just to give you an idea, you can get 1 or 2 points, the lowest score being 1 or 2. 3 or more on that particular scale gives you 2 points. So it's very quick and easy to do, and we'll see how easy that is to manage here in just a minute. Then we have I for intensity, and here we're looking at outpatient visits in the past year or emergency department visits in the last year. And so with the outpatient visits, if you have 2 or more, then the patient would get 2 points. And if they've had any ER contact in the past year, they get 3 points. And then finally, time in the hospital. This is divided into various lengths of stay. As I said, 4 to 14 days will get the person 4 points. If you keep them longer, 15 to 28 days, it goes down to 3 points. And then if they are going to be in the hospital 28 days or longer, they found that that's actually 0 points. So again, the range is 0 to 41. The highest range, the one that we're most concerned about, is 26 or greater. All right, so let's look at what this looks like as it's being filled out. Next slide. Yeah. So this, I want to put this up to give you an idea of what the drop-down choices might look like and how the slide might look as you're filling it out. You can see there that the top is already filled in a little bit. You can see how those values, it will automatically give you some points that are added up there at the bottom. We're currently on the D, the diagnosis section, and this particular one is showing that the person has depression, and so that automatically you get 2 points showing up there. And so each of these choices are going to add up. You just pick from the drop-down menu. The points will add up for you, and then we'll see here in a minute. What happens is they get highlighted using a red, yellow, or green stoplight type of an approach to give you an indication of low, medium, or high risk for readmission. So what I'd like to do, as I said, is take a minute to go to the medical morbidity and Charleston comorbidity score and show you just quickly how we've helped to make that a pretty quick process for you. Next slide, please, Ken. So I know you can't read this slide. It wasn't intended for you to read. It's just intended to give you the idea. On the second tab of our Excel document, we have the instructions, and I've got the big arrow pointing to a hyperlink there that will take you, you just click on it, takes you right to a web link that we're going to see in a moment that will, again, automated to run you through the Charleston comorbidity scale and give you a score. So this tab will run you through all the instructions, but it's also where you find a link to the Charleston comorbidity index. And then when you get that, you can just go back to the patient form to put it in to the table. So let's go to the next slide and look at the Charleston. So if you look at the Charleston, the first one is patient age. So you get a certain amount of points based on the age of the patient. And then really quickly, it's simple yes, no to any of these various comorbid conditions that the patient might have. So you can tell that this is a pretty quick assessment to do. You just simply click on the ones that the patient has, and then there's a calculate button, and boom, they'll tell you what the score is. And to remind you, when you go back to the readmit, if the score is 1 or 2 on the Charleston, then you get 1 point. If it's 3 or more, you get 2 points. So it's, again, it's pretty simple. So to give you a simple example to go by, let's say we have a 65-year-old being diagnosed with diabetes that's being admitted. If you were to fill this out between the patient's age and having that one comorbid condition, the patient would get a Charleston score of 4. And since that's more than 3, this patient would end up with 2 points on the readmit. So, pretty simple process. So let me, next slide, let's take a minute and go through a quick case example. I think this might be the best way to give you a quick idea of how easy this is to use. So this patient being admitted to the hospital today is complaining of depression and suicidal ideations with a plan. He's a 31-year-old white male with bipolar disorder. He's been hospitalized on 3 previous occasions in his life, and he left his initial hospitalization AMA feeling angry and believing that his diagnosis wasn't correct. He has since acknowledged the diagnosis and begun outpatient treatment, but he's been hospitalized on 2 additional times due to severe depressive episodes. In the last month, he presented to the emergency department with suicidal ideations, but was sent home in the company of a friend with a safety plan to follow up with his therapist. He denies any significant medical issues. So not too unusual patient for an IPF to see and perhaps being admitted. So let's take a quick look, next slide, at what his readmit might look like. So you can see at the very first, he's had 3 admissions prior today. So that gives him 5 points. He admits to current suicidal ideation. That gives him a point. He's 31 years old, so that's 7 points. And then he's diagnosed with bipolar disorder, which is 4 points. He did have 1 unplanned discharge when he was first diagnosed, so there's 5 points attributed to that. He does not have any medical comorbidities, so there's 0 points on the Charleston comorbidity score. He has had more than 2 outpatient visits in the past year working with his therapist, so there's 2 points for that. And then he was in the emergency department the last month, so that's 3 points. We are hoping that we'll be able to treat this young man in about 14 days or less, so we're going to put 4 points in there. And you can see here, total score there is 31, and there's your red highlighted risk of readmission saying high. So one of the things that I think is interesting about this particular situation is that this patient is probably not too unusual for our IPFs to see, and sometimes we see even more difficult patients than this. I think it would be understandable that we get used to seeing people like this and may not necessarily think that this is going to be someone at risk for a 30-day readmission. So the Readmit tool perhaps can give us sort of some data to look at to remind us that, hey, pay attention, this guy actually has enough risk factors to warrant some additional attention and guidance throughout his hospitalization to ensure that he has adequate support when he's discharged and reduce the chance of his readmission. All right, so that's kind of an overview of the Readmit. I hope it's been helpful in helping you to see how we can use this to identify potential high-risk patients. Now Barbara Link is going to help us by showing some of the tools and things that we've created to hopefully help you deal with patients.
Hey, John. John, this is Candy. Just before we get going with Barb, I think I wanted to make sure that you mentioned the point about the 1 point increase in readmit and how that that percentage of readmissions goes up. Sure.
Candy's talking about, and this is something that came out of the research on this tool, that it's a 0 to 41 point scale, but the researchers found that even a 1 point increase in the readmit score increased the odds of a 30-day readmission by 11%. So that it's really huge. Each point that they get on this tool can have a huge impact on their potential for readmission. Thanks, Candy. I appreciate you bringing that up.
Yep. Thanks, John. That was great.
Barbie, there?
Let's see. Maybe I can unmute Barb if she's having trouble with that.
Oh, scroll down maybe. Is there a way to scroll down?
I think that's good. I don't know what happened to Barb.
Andy, I'm noticing that our phone lines seem to, oh wait, here we go. Maybe she's there now. Barb, are you there?
She was on, oh, there she is. Okay, okay, let's see what happened here. Oh, she must have gotten disconnected. Looks like.
I see that her video is still up, but she was joined by phone.
Sure, so,
She can hear you.
oh, she can hear us?
Yep.
Okay.
Is she on the phone? She's going to try to relog in.
So Barb, you can try unmuting your phone line, Barb.
Make her, try to make her.
Should I make her a host?
Make her, make her a co-host.
Oh, yeah. Let's try this. Hang on a second. Sorry about the technical difficulty here. All right. So, Barb, I just made you a co-host. And I can see your camera's on, but I'm still not. Is she responding here still? Sorry, folks. Hopefully we'll get Barb up here in just a couple of seconds. Otherwise, we'll just.
Can you hear me now?
Oh, yep, we got you, Barb.
Okay,
Yep,
I had to apologize, everyone. I had to hang up the phone line and come in through the computer, but I sound all right through the computer?
Yep, you're just fine, Barb. Great. So you're doing great. Thanks.
All right. Sorry about that, everyone. Glad you can hear me now. So I did want to thank John, even though there was a little bit of a delay. So I'm going to talk now about tools and resources that the Lake Superior Quinn Regional staff developed. We compiled some new resources and we targeted them specifically at IPFs for their use when working to reduce their readmission rates. So next slide.
Hang on a second, Barb. There we go. Okay.
Great. All right. So one of the areas that we decided to focus on were some specific readmission toolkits and practices that have been developed. One of them is the project Reengineered Discharge, and that's Project Red. as you can see, this nice one-page, so it's a pretty extensive toolkit. Researchers at the Boston University Medical Center developed and tested the Reengineered Discharge. Through research, they really found that it was an effective way of reducing readmissions, post-hospital emergency ED visits as well. And so what the staff at LSQIN decided to do was to develop this one-pager toolkit that helps you navigate through the READ toolkit is very extensive, and it has quite a few documents that are included in the toolkit. And so the staff felt that by compiling a checklist, it would help to navigate the toolkit in an easier to use fashion. It really is able, if you'd like to go to the next slide. So the thing that's very nice about this is that it really does lay out the steps for implementing READ standards. But through the checklist, it provides an easy to navigate list of the full toolkit from initial steps of gaining leadership buy-in all the way to monitoring the implementation and outcome measures that are part of the READ standards. So you can actually go to different sections and check out different components of it, and you don't have to go through the whole very large toolkit, so you can target certain areas that you might be interested in. And we thought that would be very beneficial than getting a little bit overwhelmed by the extensive toolkit that's Project READ. All right, next slide. The other thing that we felt that would be important to do was to develop some additional resources for IPFs. We certainly know that there's a lot of resources out there regarding readmissions and reducing readmissions for the medical component of hospitals, but specific to behavioral health issues, there wasn't as much out there. So we thought that we would develop sort of targeted information for the IPFs to use. And so we developed this IPF resource flyer. Many of you might have seen this flyer in the past, but what we decided to do was to update it and streamline some of the resources so they would be current and easy for you to use at your facility. So included in this flyer is information on readmission reduction models, articles, tools, and handbooks that provide innovative strategies specifically for IPFs in reducing readmissions, and then different toolkits that also assist patients and their caregivers in working with IPFs and dealing with discharge issues. The other thing that I find that's very helpful about this is everyone, and we'll talk a little bit more about this at the end of the presentation, is that all of the IPFs listening today should have received these tools via email by now, the Project READ checklist, as well as the Inpatient Psychiatric Facility resource. And once you receive them via email, then all you have to do is click on the hyperlinks in the document and it takes you right to where you want to go. It takes you to further information and it takes you to websites and gives you more details about the specific article, toolkit, or resource that we've provided. All right, next slide. So now I'll just give a brief overview, kind of a high level of some of the resources that you'll find in the IPF resource document. I always have liked the bridge model. It is a standard readmission reduction model, but the thing that makes it somewhat unique to other readmission models is it is very person-centered and that it's social work led. So it really looks at an interdisciplinary model of care. It involves community organizations in the discharge planning to reduce readmissions. And it even includes the aging network. So it's focused on the older adult population. All right. Next slide, please. We also included the Roadmap to Behavioral Health Care, and this is a pamphlet that is patient-centered and a self-advocacy tool for behavioral health patients.
It helps patients to understand how their insurance coverage and what are some of the best ways to use their insurance coverage to improve their mental and physical health. And it also provides 8 steps that provide important information on behavioral health issues as well as navigating the behavioral health system. So it is very easy to use. It's a brief pamphlet, but it's something that's very focused for your patients that can help them, once they're discharged, sort of navigate the healthcare system and stay in the community longer. All right, next slide. So the RARE, Reducing Avoidable Readmissions Effectively, is another readmission reduction strategy that is housed on the flyer. And as you can see, the website is here in the slide deck, but it's also, you can just have that flyer as a one-stop shop for yourself and find all of these resources. This particular readmission reduction intervention provides 5 key areas to focus on: comprehensive discharge planning, medication management, patient and family engagement, transition care support, and transition communication. And all of these factors we know are very important in the IPF setting, so we thought it would be good to include it in our resource flyer. Right, next slide. And then, oops, yes, RARE is another readmission tool, and it focuses specifically on addressing readmissions for mental health and substance use disorder population. And it is very targeted at that population, so it is incredibly helpful in the IPF setting. And the last slide. So John went over the Readmit tool in quite a bit of detail. He showed you the Excel spreadsheet. He showed you the comorbidity scale, and all of those documents, even the other components of it where it provides instructions and such for populating the Excel spreadsheet, are all housed at that website, so you can easily find it. It even has a link to the original article that John was citing today in his presentation as well. So if you're really interested in trying to integrate this into your EHR, or if you want to just give it a try on a few patients, all those documents are found linked into the flyer, and you can get them all just by going to that one link, and you can download them there if you're interested. So, yep. So again, I just wanted to reiterate that if you're an IPF that received the invitation to this webinar today, then you should have received all of those documents, the checklist, as well as the behavioral health flyer via email. If you have not, Candy, John, and I, all of our contact information is listed on the very last slide, and you can always reach out to us and we'll easily send all that information to you today. So, thanks very much, and I'm glad you all could hear me.
Yeah, thanks, Barb. So we have a few minutes left. So I just wanted to open it up now. At this point, I've unmuted everybody, or at least I believe I have unmuted everybody. And just wanted to know if anybody out there has any questions, or if anybody is wanting to speak up here and share, you know, any other resources that they've found to be extremely useful in reducing readmissions, or just questions in general about anything that we've presented today. We'll give people just a couple minutes. See if anybody does have any questions or comments or anything.
Candy, this is John. I'd just like to say we've had some folks express interest in trying to implement the Readmit, and we're more than happy to talk with you more about putting together a pilot if you are interested in that.
Sure.
We've had some interest actually from the East Coast, from a hospital out on the East Coast. So we've sent some of the information that way as well. And they've actually indicated that, you know, like Barb said, they would like to integrate it into their EHR so that it was more readily accessible for use. Great idea. I don't think it would be terribly difficult to do that, you know, since it's already pretty much laid out.
Yeah, agreed. No, I think to me, it looks like a great tool. It would be good to have some folks pilot that or whatever and just see if it, you know, if it was a really good predictive indicator of readmissions. Absolutely.
Hi, this is Jackie from Detroit, Wayne.
Hi, Jackie.
How are you?
I
just had a question. Can you, any of you, talk about what the readmit rates, so what it was prior to using some of these tools and where you are now with it?
So, Jackie, if I'm understanding, you're wondering what it was prior to us creating the automated tool. Is that right?
Yeah. Yeah.
It was a study done by researchers out of Toronto, University of Toronto, and they had not automated the information, but they had an extensive study with lots of tables and charts and, you know, 32,000 sort of population that they worked with. So it was primarily just one of the first studies trying to identify a model for psychiatric patients or psychiatric hospitals, right? Because we didn't have that prior. You know, we had the LACE and some of the other general medical readmission risk stratification tools, but there was nothing really for the behavioral health or psychiatric population. So they did this in 2014, and we learned about it in the course of our work with the IPFs. And one of my colleagues said, you know, we could automate that information to make it even easier for people to use, because there wasn't really a tool like we just showed you that would make it easy to use the study. The study, as you know, studies are multi-pages and very in-depth and complicated. And so we took all that information and automated it into something that we hope is very simple to use and quick to use, so that you can get an idea of what patients might benefit from Project Red or RARE or whatever kind of 30-day readmission risk reduction you're trying to do. So that's kind of what we've done with it, and we're really interested to work with folks who might be interested in doing a pilot. Our idea is maybe to do a pilot for a quarter at least, and then look at that in comparison to a previous quarter to see.
Okay.
Right? Does that help answer your question?
Yeah.
Can you hear? This is Barb. Can you still hear me?
Yep, we can hear you, Barb.
Yeah.
Okay, because since Jackie's from Detroit, I wanted to also, I think the other thing is, since you're with the Department of Mental Health, so this initiative was focused on recruited IPFs in the 3 states, and all 3 states have been promoting the Readmit tool. And in Michigan, the group of IPFs that we work with here all were very excited about it, but I think the challenge, I'll just talk about a little bit of a challenge, was trying to integrate it into the EHR so it was easy for staff to use. And so, as John said, it's still sort of pending. We've got some buy-in, but I think, you know, sometimes those EHRs can be a little challenging for people to, you know, try and put new things into. So they all were very excited to see that it was targeted at the IPFs and not just a general medical risk stratification. You know, we're trying to test it with one of our IPFs that we're working with right now. And the only other thing I can speak to overall through our 3-4 years of this initiative, we had to keep readmission rates with the IPFs that we worked with below a baseline rate. And all 3 states did well in that area. It was a little challenging for some of us, but that was our overall goal. And as a region, we were able to maintain that goal throughout the charge of this particular task that we have. And that was done through technical assistance, education, and supporting the IPFs in the readmission work that they're doing.
Thank you.
I think that this is Lisa from Stratus Health, and I think that was a really great question. Is there data to support use of these tools? And no, because it takes, 17 years to get data and research into practice. So we're just doing some innovative work to try to put things into practice now that we can test. So it's practice-based evidence instead of evidence-based practice.
Okay. Yeah.
That's a great point, Lisa. But it is, you know, I really like what you guys did with it, John. I mean, that's the way, that's going to be the next step to getting it to the next step, is making it so that it's user-friendly and intuitive and so on, so that it becomes easier to integrate into workflow.
And Candy, I'll say that Ross Gaskey, who works with us here in Wisconsin, has been in touch with the researchers on several occasions to let them know where we are and what we're doing with it, and they're very supportive and have indicated interest in any additional work to do with it. So we are trying to maintain contact, you know, with the folks who created the model.
Great. Thanks, John. All right, anybody else have any questions or comments or anything? All right, well, hearing nothing, we'll give you all about 7 minutes back into your day then, and we thank you very much for participating in this, in our last webinar with you in this initiative, and also thank you for your ongoing participation and work to reduce readmissions in inpatient psychiatric facilities. We certainly acknowledge it's no easy task, so thank you very much, everybody. Have a great day.
You too. Thank you.